There you are. Hi, Obi.
How are you?
Great. How are you?
I'm fine. Thank you so much for doing this.
Oh yeah, I'm sorry to keep you so late. It's convenient for me, not so convenient for you, but
I don't mind. I'm
pleasure to
usually
be here.
I'm usually up by this time anyway.
Oh wow, not me. Not me. I gotta old men go to bed early. Yeah, it's good to see you. I really I show people the carving you made me of the hand holding the lens. I
Well,
have it right here. I have it right here. I have a cabinet with a lot of stuff from my travels, and it's in
wow,
there. It's a
that's
nice
nice.
memento. I cherish it.
Yeah, thank you so much.
Oh, thank you.
So, basically, it's recorded, and um, I'm just going to ask you a couple of questions.
Sure.
If there are interruptions in between, it can be edited out.
Sure.
Um, So once again, thank you so much for doing this. I'll just pull up the list of questions and then we'll start. Okay, so
Anytime.
the name of the podcast is Corneal Frontiers. I think I've been a bit lazy because I've been busy with work, so I haven't had so much time to record some episodes, but I'm hoping to kickstart it more this year. So welcome to Corneal Frontiers, Dr. Tom. I think this has been a long time. I've been wanting to do this. Thank you so much for agreeing to speak to us today from your wealth of experience. So if we could just start by introducing yourself, tell us about yourself.
Certainly, and thank you for having me, Obi. It's a pleasure to speak with you and your listeners. I'm Dr. Tom Arnold. I'm a graduate of the University of Houston College of Optometry in 1984. I worked for 8 years with various large ophthalmology groups, even did some research on the early treatment diabetic retinopathy study. And then in 1992, I opened my own private practice near Houston, Texas. I always had an interest in contact lenses, and I was fortunate enough to build a fairly large general optometry practice. Eventually I had two other partners with me, and now about 18 years ago, well into my career, I started becoming interested in scleral lens technology. In the last 10 years or more than that, 12 years of my practice, I focused on specialty contacts, particularly scleral lenses for eye diseases. And I retired a few years ago, but I'm still active speaking, and I still consult with some companies. And so I keep
Oh,
active, keep my mind active. And
that's great.
optometry was such a great career for me.
Wow, nice to hear. And I guess you enjoy retirement.
I am. Yeah, I keep busy. My parents, who have since passed away, used to tell me that they were busier than ever, in retirement, and I used to laugh at them. But yeah, I have no problem being idle. I have a lot of different outside interests,
That's
and
great.
still active. I mean, last year I visited about 6 countries. I
Oh,
was
wow.
speaking with Dottie Fidel and her Euroschool, and I did that. And of course, Melissa Barnett and I have our meeting, the International Congress of Scleral Contacts, which we have in Florida every July. So we're really starting to concentrate on that.
Hmm.
Um,
So,
so, and I still write and speak.
yeah, well, you're here today, so obviously you do like to speak. How did you get into scleral lenses? Why scleral lenses? I mean, there are other specialty contact lenses, orthokeratology, corneal RGPs. Why scleral lenses?
Well, that's kind of a story that I've told often. So I hope your listeners will forgive me if they've heard this already. But I always liked contact lenses. I was a teaching assistant while I was in optometry school to the cornea service. I was very, very fortunate that my anatomy professor was Dr. Jan Bergmanson, who is, of course, world famous, still active,
Very, very active.
years old, still active. And his
Yeah.
book, the cornea, a complete, the corneal anatomy or
Yeah.
ocular anatomy is in its like 28th printing. So I worked with him. So I always liked contacts, and I always did specialty contacts. I did We always did a lot of RGPs. We did bifocals and torics and all those things. I was an early adapter to the hybrid lenses. So always enjoyed specialty lenses. But as my practice grew, and it was a general practice, we did a little bit of everything. I became aware of scleral lenses probably 2008, 2009, something, when the Jupiter lens came out. And I was approached, by the labs, and I just thought at that time our practice was very busy with general optometry, and I just didn't feel I have time for that. Anyway, the story is I did have keratoconus patients that, I was fitting with the RGP cone lenses, maybe some hybrids. And I was very fortunate to be very good friends with a cornea specialist who we graduated about the same time. We worked together at a big ophthalmology group in Houston. And he was my main cornea resource. And I had two keratoconus patients within a short period of time, and that I saw, and they were both advanced, didn't have anything to do with each other, but in a short period of time, these two patients came in, and I thought they needed grafts. Their keratoconus was so advanced, I thought, go get your graft done and come back, and then we'll keep going. But I sent him to my friend, and he was the one that recommended scleral lenses. It was actually an ophthalmologist, who really was on the cutting edge. And he said, no, you can fit these people with a contact. And so I reluctantly started doing that. I went to a day course that was held in Dallas, Texas. I was in Houston, hosted by the Gas Permeable Lens Institute, or the GPLI, which I'm sure you're familiar with. And it was a day-long conference, workshops and lectures on all things rigid. There was only one talk actually on scleral lenses, but there was a workshop, a wet lab, and Greg Denier, who's very well known at in the Arena Eye Associates in Ohio, and he's associated with Visionary Optics. He was leading the workshop, and he put a scleral lens on my eye. I didn't know Greg at the time. I'd never met him before. I didn't know his role, but he put this lens on me. And I went, wow, this is comfortable. This is great. I'd had LASIK, so my vision was good, but it seemed to be even sharper with the lens. So I thought, well, I need to do this. And, not knowing anything about it, I went out, and one of the vendors was there, and I said, do you have scleral lenses? And I go, yes, we do. So I ordered a kit, and it showed up in my office about 2 weeks later. And of course, I had forgotten a lot by that time. And I opened up the kit, and there was sags, and there was, increased lift and decreased lift and edge flat. And what is this? But I had the kit. And so the next keratoconus patient that came in was a young lady that I'd been seeing a long time. And she had a corneal RGP. And I saw her for her annual exam, and I said, I had these new lenses. They're supposed to be good. They seem, like they seem good. Would you like to try one? She goes, yeah, sure, Dr. Arnold, whatever you say. And so I went to my kit, and I just kind of read and went, okay, this one, and I filled it with saline, and I put a bunch of fluorescein in it, and I put it on her eye, and she just went, this is great. I was very lucky. It cleared, it landed. She just put on, went, oh, these are super. I want these, because she'd been wearing the small, it's probably 8 millimeters or something, some tiny thing. So the light went off, and I just said, this is what I would like to do. So that's what I started doing.
Well, that's a great story. So just out of curiosity, what diameter were those lenses that you started fitting?
It was a Blanchard. It was a Blanchard, what they call the MSD, or mini scleral design. I believe they were 15.6.
Oh, okay.
They only had two offerings. It was the 15.6 or the 18. And in the kit only had one diameter. So they were all 15.6. They were available in 18, which seemed massive to me. I never fitted 18. I never, everybody got that lens for like 2 years. you know.
Yeah.
And then can we talk about brands? Is that okay? In America,
That's okay. There's no, yeah,
we can talk about brands. Okay.
Yeah, we can.
So, about that time, I had made friends with Nate Schramm, who I know you know. We developed a friendship, and we were writing back and forth. I think I actually went to visit him. Maybe this was after, but anyway, we started this Scleral Lens page, which the Scleral Lens practitioners page on Facebook. Nate started it and asked me to help. So we started doing that, and he was posting about Zen lens, and he had several different posts. And I wrote him and said, "What's this lens? You're talking about it. What is it?" He said, "Oh, it's great. It's a real good lens." So I thought, okay, well, let me have that. And so I got Zen lenses and I started using them. And I forget what they were. They were like 16 and 17, I believe. Yeah, I think so. I think they were 16, 17. So I started using that. I like that, but I've been, I continued to use the MSD, and then they had other designs. And so from that point, I just wanted it all, so I ended up trying a variety of lenses. I used a variety of lenses. I was fortunate as I continued along this road, I was asked to do beta testing for a number of manufacturers because I had the volume, because I was, I went out, I marketed my practice in this. I visited other optometrists and other ophthalmologists and even rheumatologists, for dry eyes, autoimmune disease, and so forth. And so I went out and built this segment of my practice, consciously, by asking for referrals and so forth. And so I got to beta test a lot of stuff, because people knew that if they had a product, that I could put it on some eyes. So I got exposed to a lot of different lenses, and I enjoy that. And people, I was speaking yesterday. Yesterday I was speaking at a conference in Denver, and the question comes up: well, what's the best lens? What should I get? And there's no right answer for that. And my analogy, Obi, is this: I used to be in a marathon club. I used to run marathons, and had my group of buddies. We call ourselves the gray hairs because we're all older. We all have gray hair. So I ran in this little club, and there was a group of about 8 of us. And I tell you what, you can look at their shoes, and they're all different. I mean, some of us were in Brooks, some were in Adidas, some were in New Balance, some I don't know, a Tonic, whatever else. But no one best shoe. It's what shoe works best for you. And I think scleral contacts are definitely the same way. I think some are easier to work with to others. Some were probably easier to understand. But you clear the cornea, you don't insult the limbus, and you try to align to the sclera. And a lot of lenses will do that. So I think we have to keep an open mind, not be dogmatic about one brand.
I totally agree. Now, interesting, you mentioned about the first 2 patients you had to fit scleral lenses on. You actually considered sending them for penetrating keratoplasty. So that brings us to today's topic. I'm sure you have experience fitting patients post-penetrating keratoplasty. Are there any specific criteria that you look out for before you fit these patients? Or are there certain parameters that you look at and you say, okay, I'm going to fit these patients with scleral lenses, or I'll go with a corneal RGP with this patient? What are those parameters that you look at?
Yeah, a great question. And again, different practitioners have their opinion. I think the main question is this a mature graft? Has this graft been here for many years, or is this a new graft? Okay, so that guides your decision making there. Most of my patients that I fit were mature grafts. They were grafts that had been around for a long time. And so with the mature graft, whether or not it still had sutures, some doctors leave the sutures in for years. So that wasn't an issue for me. Mature grafts, I'm not so worried about because you're not so worried about neovascularization and so forth. And I personally, and this is a subject of controversy, or like my British friends would say controversy, and that is the condition of the endothelium, and are we going to induce edema with a scleral lens? And there are different schools of thought on that, and some people are very, very strong in their beliefs. And in fact, Obi, at our conference this summer, this ICSC, that is one of the topics. Muriel Shorneck suggested a session called Mythbusters. What are things commonly believed, but maybe are not true. And so there is a controversy about endothelial health, especially in an old graft, because we all. I've lost endothelial cells. I mean, we all do. It's an aging, it's an aging change, and then in a graft. So anyway, getting to that. So some people will tell you that at any graft you always want to do an RGP first because it's less insulting. But in my opinion, in a mature graft that's established, I fit many in scleral lenses. And as far as parameters, it's an oblate cornea, obviously, because it has a graft. So you want to use an oblate curve. So you don't want any more central clearance than you need. But there again, I'm not dogmatic. I'm not a zealot for some certain. Probably don't want to be less than 200 microns, up to 400. I'm not sitting there being crazy about it, as long as it clears. And of course, you have to clear the junction of the PKP, the graft. And then, align, after you clear the graft, you want to come down, not have excessive clearance over the sutures or where the sutures were, and then align. I think you can expect more scleral shape variance, more scleral toricity. You're certainly in a toric landing zone. You're probably going to have a good amount of toricity. 200, 300 microns is not unreasonable, maybe more. And you may often go with quad.
Yeah.
And what you'd have to watch for in any of those with that kind of corneal scleral profile, is make sure you don't have any areas of excessive leakage. I don't want to suck onto the eye. I want some fluid exchange, but in a thing like that, it's easy to have areas where you have too much fluid intake. You get a lot of midday fogging and stuff. So that's a mature one. Now we can talk about a new one if you like as well.
Yeah. So, I think we'll definitely have to discuss the new ones because, again, from literature and from clinical experience, you find that most grafts will lose about 30 to 50% of the endothelial cells in the first year. So I do understand the caution in fitting new grafts because you want to be sure that the cornea has stabilized, and the patient is out of the frequent rejection episodes expected in the first year. But do you find certain things like the global pachymetry or specular microscopy useful prior to fitting these patients, or you just look at the cornea over the slit lamp, look for striae or folds, or do a specular reflection on the slit lamp, and then you go from there? What do you do?
Well, we in my practice, we were fortunate that we acquired a pentacam. So that would be my global pachymetry and mapping of the shape of the cornea, anterior and posterior. I did get a specular microscope, an endothelial cell. It's called cell check. It's, I guess, a specular microscopy. We imaged the endothelium, and I looked at it. But I can tell you, but on a new graft, what drives it is, when does the surgeon say it's okay to fit a lens? So I would not start that process until the surgeon says, I'm comfortable, you can fit the lens. So we did look at it, and a lot of them look terrible. A lot of the endothelial, I mean, they look terrible, and yet the cornea remains clear.
Sure.
So in my experience, I found that I wasn't really driven by that, that I'd look at it, I recorded it, but I would fit them anyway. And honestly, the only people that I had problems with edema with were two, and that was not with grafts, really not with grafts, but fuchs, people that had fuchs. I mean, they will certainly swell, but they'll hang on for a long time. They'll have a very compromised endothelium, and they're still good and successful. But at one point, they go over the falls and they're going to swell. The other one, oddly enough, and I don't know if you've seen this, is now I can't think of it. What are the deposits on the anterior surface of the cornea? What are those plaques that we get? What is the name of that?
The protein deposits?
No, they're not protein deposits. No, this is in the cornea. What am I thinking of?
Is it a dystrophy?
What's that?
Gelatinous dystrophy?
No, it's not a dystrophy. It's the plaques that grow, the big opaque areas that grow between the endothelium and Bowman's layer there. What in the heck are those called? Anyway, I'll think of it in a minute. But they would swell. They would swell a lot. So those are the.
And in those patients that did swell, how did you monitor? Did you have to do global? Well, from my experience, I've only had one case swell, and this was post penetrating keratoplasty. But I didn't fit the patient initially. He had been fit somewhere else and presented complaining of cloudy vision after about 2-3 hours of scleral lens wear. Surprisingly, the patient did have about 20/40 vision with the lenses, but we had fluid reservoir thickness of about almost 800 microns centrally, with a very decentered lens and neovascular vessels getting into the graft.
Yeah, that's not good.
So I did have to pull the patient out of scleral lenses for a couple of weeks, then did the global pachymetry, refit the patient, and then monitor the pachymetry afterwards. Do you find that for those difficult patients, you have to use monitor the pachymetry before and after fitting the lenses? Or do you, once you're able to get an adequate fit, you just monitor from there and go on from there?
I think in the initial stages, I'd monitor it and make sure I didn't have swelling with global pachymetry. But again, maybe there is a school of thought, as we've talked about and you mentioned, that on a new graft you should try to fit them in a RGP, corneal lens, and you can certainly do that. You certainly can do that, and then you don't have all these issues. But on the other hand, I think a lot of them patients with a well-fit scleral lens, even on a newer graft, can do quite well. Once we feel like the graft is secure, and it's fairly easy to do because we have very high decay materials now. There are good studies. I told you I wasn't a clearance fanatic, but it does make a difference. So as long as you can keep it in a decent range. I don't think swelling's a big thing. And also the quality of the graft. And I realize that varies, quality of the graft. In America, we're pretty fortunate. I think the surgeons have access to very good material. Maybe in the rest of the world, it's not as good. But But I tell you what, it's interesting because I worked with a lot. Like I said, the first 8 years of my career, I spent with ophthalmology groups, and then of course had very good relationships, in my own private practice. And I think optometrists, we worry about things, what might happen if we do this. And the surgeons are very cavalier. They're very cavalier. I had one patient. Out of many, but one comes to mind. And she had a very mature graft that was still very good. This lady was in her mid-60s, maybe, and her graft was 30 years old. And it was unilateral. It was only in one eye. And it looked good. I mean, it was still in very good shape. and she came to me for scleral lenses. She was referred to me by a cornea specialist, not my friend that I described, but another one that I had a good relationship with. He sent her to me for scleral lenses, and we fit them in both eyes. Anyway, she did quite well, but over a couple of years, and this I did have the endothelial cell count camera and was monitoring her, and the surgeon would see her periodically, the cornea specialist. He had not done the surgery, but he told her, she told me in a subsequent visit that her cell count went down to 400 cells per millimeter square, however they measured it, and I had measured it in 800 or so. And she came on her visits and said, the doctor, mentioned to me that this was happening. And I went, oh, well, that is a concern. So I called him up, and I knew him well. I called him up and he said, oh, yeah. He said, yeah, that's true. He said, but it looks good. So don't worry about it. Carry on. And I said, well, I don't want to be the one to, cause this to fail. And that's what all of us, all the optometrists, don't blame me for making this graft fail. And he goes, oh, well, I'll just do another one. They don't care. They absolutely don't care. At least I know that. Oh, it's going to fail. Oh, good. Well, I'll just do another surgery. That's what they do. They do surgery.
Exactly. So we're worried about things that they don't even bother about. And in the course of preparing for this podcast, I did come across some papers where the graft was still clear at 500 millimeters square, so cubic meters rather. So if the endothelial cell count is down to 500, which I would personally may even consider a contraindication for fitting scleral lenses, but if the cornea is still clear and it's a risk we're willing to take, why not? So I agree with that.
Well,
in your experience, do you find certain modifications useful? You did mention material change with high decay materials, fitting close to the cornea to allow improved oxygen transmissibility. Are there any other options or things that you look at? For example, channels, fenestrations, do you consider those?
The fenestrations is a very interesting question. The early lenses were all fenestrated because the plastic wasn't very permeable. So people that have been doing this a long time, like Ezekiel, Damon Ezekiel, the Boston site people, Alan Kwok, Karen Carrasquillo, and people like that. And of course, Ken Pullum. Anybody's been doing this a long time has familiarity with fenestrations. Because I came to it fairly recently with the more high decay materials, I haven't had a lot of experience with it, although I have used fenestrations on a couple of patients, and they work well. I mean, they do work well. Christine Sent and I did some work on this, and she made a very good point. Fenestrations work well. You've got to place them in the right place. If you place them in the wrong place, either you're going to get too much of a bubble, if it's towards the fluid reservoir and it's too big. And if you put them way out in the haptic, they're going to just suck on, you're going to have some conjunctiva. So Chris, and if she hears this, and she's free to correct me, but my understanding and the patients that I did with Chris, these are eye print patients, patients. And so they could define exactly where the limbus was. She likes to put them right over the limbus, right over the limbus. And so, I've done a couple patients like that. So they seem to work, but I don't think it's one of those things that you just do automatically because you think they're a good idea. I haven't found them to be necessary. The Boston site people do a lot with channels. And they're very, they're very good on that. I didn't have that experience. I mean, that I'm sure they developed a long time ago, but it became more popular just in the last couple of years. I just didn't use them. But on one hand, scleral lenses can be very forgiving. You can get away with a lot, because they're comfortable. And sometimes, there's exceptions, but lots of times things don't happen rapidly. But, if you watch and you bring them back periodically, I like to see all my scleral patients every 6 months, regardless. You can fix things. And so all these options are available to you. But, the old adage of KISS, keep it simple, stupid, and the other thing too is, and I think this is an important thing for your listeners, and especially those who have just been doing it, just getting started. And that is, there's no perfect fits. There's no perfect people, and fits change over time. And that is, the things sink into the conch and bubble or whatever. And you can really get in a tailspin, or what we say is chasing your tail like a dog chases their tail, never catching it. You can chase your tail, changing this, changing that. Is it a problem? Because you change one thing because you don't like the clearance or you don't like the landing, but then something else is affected. And then you got to fix that. And so again, my friend Christine Sent, who's been doing this a very long time, said, are you changing it because it's a problem? Is it a complication, or is it a concern? Okay, there's two different things. A concern is, I don't know about the endothelium, I'm watching it. I don't know about the clearance, I'm going to watch it. Complication is, oh, well, you have a Dellin, you have corneal melt,
You have to do something about that.
complications. So don't be changing your patients because you want it to look like a picture in contact lens spectrum.
Exactly. Yeah, I do find that advice very useful if it's a complication or a concern, because being involved in a position where I have to teach young people, people scleral lens fittings, you almost want to make every fit look perfect. And sometimes I have to remind myself, if it ain't broke, don't fix it. If it's not actually a problem, just let it be. The vision, it clears the cornea, the patient is comfortable, vision is fine. Let it go. Now, you mentioned in fenestration, if those fenestrations are put close to the limbus, would you, you did say you had experience with iPrint Pro. Would you advise some sort of peripheral haptic when you go for fenestrations, to make the fenestration stay at the proper place where you want it to be, or that doesn't apply?
I don't think you have to worry about it, because with an impression molded lens, it's going to fit very close. It's going to fit like it's supposed to. Of course they're dotted, you're going to have a dot to put it in. But even if it's a little off, it's going to fit where you want it.
So it
more
like
so than any other lens, because you've taken the mold. And so you have a continuous curve, that follows the contours of the eye.
So assuming it wasn't an impression scleral lens, say
it was.
The other ones.
Okay.
Would you advise toric haptic if you were going to do a fenestration on a lens?
Oh, yeah. I almost always use toric haptics. The studies that Greg Denier and his team did, published in 2017 on scleral shape. I'm sure, I know you're familiar with it. If your listeners aren't, it was a 2017 paper where they took 140 patients and mapped the scleras of these 140 patients. And I know these data well, because comes up about every lecture I've ever done since 2017. But only less than 6% of the scleral shapes were what they considered spherical. About 28% were considered toric regular, meaning they were with the rule or against the rule. They were steeper in one meridian, they were flatter in another meridian. That's about 28%. And then another 40% or something, the vast majority were what they called asymmetric. And what that means is maybe they were steeper in the vertical meridian and flatter in the horizontal, but the amount of steepness varied 200 or 300 microns. So say at 12 o'clock, they were minus 200 microns, from a best fit sphere. And then the bottom, in the same meridian, now it's 6 o'clock, they were 100 or 350, so they're very different. And that was 40%. So, and then the last 25% or so had no pattern at all. They had no discernible pattern. And so what that really means is that even in your toric haptics, where you say, this haptic is plus 100 microns above the sphere, and 90 degrees away from that, we want minus 200, for 300 microns of toricity. You're going to be off by 100 or 150 in one of those meridians, or one of those edges, 12, 3, 6, or 9. So yeah, it's a crazy thing.
Yeah, it is. Now, looking at the grafted cornea, it's actually an irregular cornea. Most times, I'm not even worried about clearing the graft. It's usually the graft host junction. But by the time you've cleared the graft host junction, sometimes you find some other areas have excessive clearance, and other areas the clearance is acceptable. How do you deal with those kind of patients? Do you decide to watch that specific area where you maybe have excessive clearance, or you just go with it? Or do you find adjusting the fit based on profilometry helps with the centration of the fluid reservoir, or makes it better? What's your experience with that?
Well, in general, if it's not, you're absolutely right. It's not going to be even all the way around. It just is not going to be. As long as it's not excessive in one area, I go with it. You may be 200 here and you may be 450 over here. Because of the tilt of the graft. You leave it. Again, if it doesn't cause a problem, I'm not worried about it. If it affects centration or something, then you have to deal with it. And what you might do in that case is you'd steepen the lens, you'd steepen the base curve so that you would come down a little more, and not have that excessive clearance in one meridian. So that's where you work with your lab, and see what options you can do. One meridian than other, but it's very difficult to get it all even because the eye's not even.
Mm-hmm. So at this point, I remember an advice you gave me about using the elevation map on your corneal topography data.
Absolutely, yeah.
And looking for the most elevated point on the cornea, clear that area, then you look at the other areas. So I think that advice has actually helped.
Well, thank you. Yeah, the talk I gave yesterday was on astigmatism, and I went back to elevation maps again and again and again. Because I think it's easy, and I was certainly guilty of this. We look at axial maps or even tangential maps of say just keratoconus. This big red spot, you got this great big deal, this big red looking at you. And, we're used to talking to our patients and pulling out these little plastic eyes and showing them this cone cornea, it's missile. Well, this is keratoconus. Or you show them a picture and we look at that axial map and we go, well, there it is, It's not it. That's the curvature change. That's the power change. You look at the elevation map because that's the contour of the cornea. Yes, you're absolutely right. So I'm sure glad that you're teaching your students that, because that's a very important.
I try to teach that, and I recently I can't remember where I learned this technique, whether it was during fellowship or maybe from a webinar, I can't remember. Sometimes, again, because I practice in Africa, not too many people have access to certain facilities. So I find if you put a GP lens, a corneal GP lens on the cornea and stain with fluorescein and look at that pattern, you might find the areas that touch, and then you know what areas are more elevated. So it gives you an idea of the topography of the cornea, assuming you don't have a topographer.
I'm going to send you a picture. I'm going to send you a slide off my lecture that I did yesterday and last week. You might be interested in it. It was on Wu University.
Oh, okay.
You
Yeah.
tune in on that? Woo
Yeah,
you?
I do.
Yeah.
Yeah.
WOOU.org.
Yes, definitely will. Yeah.
And they have they're on YouTube, and
Yes.
that's my lecture. But I'm going to send you a picture, a slide from that, and
Mhm.
it's exactly that point. The slide has three pictures. It has an axial map,
Mhm.
it has an elevation map,
Mhm.
and it has a corneal RGP on this eye, and the eye is scarred. It's a scarring issue
Mhm.
and, due to an injury.
Yeah.
And if you look at the fluorescein pattern of the RGP
Yeah.
and you look at the elevation map,
Mhm.
they match exactly.
Sure.
So the point is the elevation map will
Yeah.
tell you what your lens is going to look
Would
like.
look like.
Yeah,
Yeah.
I'll send it to you. You can
Thank you.
one of your talks, but
Thank
it's
you.
just a great example. Yeah.
Yeah, I agree totally. Now,
I want to go back to one thing real quick
sure.
about the mid periphery. There
Yeah.
are lenses that you can adjust the mid peripheral clearance without
Mhm.
central clearance.
Yeah.
Okay, so
Yeah.
you can specify that. So let's say you had a reverse curve, an oblate
Mhm.
curve, because you're fitting a graft.
Mhm.
You can have that central clearance,
Mhm.
and then as you come to the mid peripheral junction, you can adjust that. Now,
Oh.
it'll be adjusted 360 degrees. That's not quad.
Mhm.
But when you go to the from that mid periphery out to the limbus, you can make that quad. And
Yeah.
that'll help because going back to a different subject, is that Dottie Fidel and Christine Sent and Jason Jedlicka and a lot of people, I'm sure more than I can recall right now, have confirmed that the limbus is oval. The
Yeah.
all our limbuses, limbi
Yeah.
or whatever that is,
Yeah.
are everybody's limbus has
Mhm.
some sort of
Oh,
oval shape.
yeah.
And Chris's studies in particular from molding have shown that the short meridian, the short chord, so to speak, is
Yeah.
also higher. So
Yeah.
Chris and Dottie talked about our limbus is shaped like a Pringles potato chip. Do you
Exactly. I was
know
going
what
to say
Pringles is?
that.
Yeah, Pringles looks like a saddle, right?
Yeah.
It's also a map of the universe. It's the map. It's the universe. It's a big. Is are we flat? Are we
Yeah.
closed? Are we
Exactly.
like saddle shape? So
Yeah.
Windows comes up a lot, but our limbus is like that. And so even when they do a graft, you still have to deal with that. So the other alternative, talking about evening up the clearance,
Mhm.
is to see what you're doing over the limbus, and that will help.
Yeah. Yeah. Oh, that's a great tip. Thank you very much. Now, are there any materials that you prefer to fit for patients post graft? Are there any specific materials, or you just go with the highest DK your lab is willing to offer?
No, yeah, I think um, there's a trade-off, maybe in stability and wettability, although those have gotten really, really good.
Mhm.
So if you ask, yeah, I mean, I like the Contomac products out of the UK.
Mhm.
They work very, very well. They wet well. See if I can remember. There's extra, extreme, no,
Yeah.
extra, and then infinite, and then extreme, or I think it's
Yeah.
extra, extreme, infinite, or something like that. And so,
Extra extreme infinity. Yeah.
is that what it is? Yeah.
Yeah.
So I think a lot of them were just optimum extra, which I think were 120 DK, and
Mhm.
then the next level was like 154. And then I think infinite was supposed to be 200, but they said no,
200. Yeah.
it wasn't. It was 180 or something.
Mhm.
So I was comfortable. I did a lot of the extra, and then when extreme came out, I did that.
Mhm.
It was great material, wet real well. It was very good with hydropeg.
Mhm.
Didn't scratch. So I like that product. Of course, Boston. Boston's a standard. They're
Yeah.
very, very good.
Mhm.
So,
Okay.
but there are other plastics too.
Yeah.
Acuity has come out with one.
Wow.
Acuity with is a DK of 200. And
Mhm.
I've used that, and that's a very good lens, and it wets very well.
Okay.
So I think it's called Acuity 200.
Okay.
Yeah.
Now, looking at after you've selected the lens for these patients, you fit them, you've got the great vision. What's your follow-up regimen like for patients with who you fit post-penetrating keratoplasty, aside from your regular scleral lens visits, what are the tests that you would want to do? How often would you want to see these patients? What tests do you do when they come in? What concerns are you looking at when they come in?
I like to see everybody every 6 months, regardless, just because of these lenses.
Yeah.
So the post-op or follow-up regimen would be they come into the office. Obviously, we tell them they have to be wearing their lenses at least 3 or 4 hours, so we don't so they settle.
Yeah.
So we would see our follow-ups late morning or early afternoon, something in the afternoon. They would vision, discuss what's your wearing time. They would describe to the technician what solutions they were using. The technician then would dab them with some fluorescein on the superior bulbar conjunctiva, so it can see a little, some movement. Then they would take them to the OCT. I never used an OCT to fit lenses. I don't think you need personally an OCT to fit a lens. But it's very useful for monitoring clearance, wearing. So it's an easy thing to do. So they would next take them to the OCT, look at the clearance, maybe look at the edges for me, just take a good picture around. I had a Zeiss OCT. And then I'd see them. And obviously the vision would be checked. And, again, I'd slit lamp them. I'd look at the OCT, what's the clearance, and, get their history. By that time, I would expect to see some fluorescein in the fluid reservoir, so I want to make sure it wasn't sealed off. Slit lamp them. If they had any vision concerns, I'd do a quick over refraction and look at them. I guess for PKs, annually I would take them off and probably scan them again, look for pachymetric changes. But I'm really not worried about it. You're going to see, if you have edema, you're going to see it. You're going to see stria. You're going to see clouding. The vision will be down. So I don't know.
So what complications, if any, have you seen in patients fit with scleral lenses post-penetrating keratoplasty? Aside from edema, have you seen graft dehiscence or wound gaping, anything like that?
I never have, I never have. But of course, I see those patients, but they're mixed in with general keratoconus patients that don't have grafts. And as you know, I'm sure you're aware that the number of PKPs, the number of grafts performed, have gone down in the last few years because of our lenses. So actually, Obi, most of the PKs that I fit were existing PKs. They were long standing. I didn't do a lot of new ones. So the answer is no. I didn't see a lot of complications.
That's
I saw we had one case of graft rejection, and that was fairly early.
Anyway.
That was rejection. We sent him back to the cornea specialist, and he put him on a bunch of steroids, aggressively. He cleared up in a few weeks. But no, I haven't had that many problems, knock on wood.
Well,
but again, touch wood. But my experience, an experience of someone who works within the cornea service, where they're doing that they're going to see more of that than I would.
So again, that's reassuring because for someone who's fit that many scleral lenses, again, I have had a couple of maybe graft dehiscence or wound gape. Maybe that again, for the wound gape issues, might be maybe fitting the scleral lenses too early before the graft host junction gets to form properly. So I wouldn't totally blame that on the scleral lens itself, or the fit of the scleral lens itself. So any final words in terms of scleral lens fitting and penetrating keratoplasty?
No, I would say, have a good relationship with the surgeon. Make sure that the communication, is good both ways, that they're communicating with you and you're communicating with them. As you know, Obi, I took a lot of pictures in my career. So I think
excellent pictures.
Spend some time becoming proficient at photography. It's not that hard. There's a lot of courses on it. And just practice. And that is very impressive to the surgeons because they don't take the time to do that. They're busy.
Yeah.
If you can take pictures and discuss with them what you're seeing and any concerns, I think it builds relationship. I think it raises your esteem in the surgeon's eyes. And just keep in touch with them. Make sure you have a good surgeon that respects you. If they don't, then find someone else.
Sounds like a relationship advice.
But no, I mean, I think surgeons in general, and this is, I've traveled a lot in the last few years, and I think this is all over the world, really have come to appreciate the benefit and the power of scleral lenses. So they respect it. And so I think they respect anyone who does a good job with it. And, for your listeners, I would urge them to go out in their community and talk to the optometrist and the ophthalmologist and anybody and let them know that you do this, that you're interested in this, part of practice, and that you're developing it and you're developing your skills, and you'd like to see their patients and you take good care of them. So I would say don't hold back. Don't wait until don't think you need you got to have a certain piece of equipment. Christine Sent says the best topography in the world is take a lens and stick it on the eye. And you had just mentioned that yourself. I'll tell you one quick anecdote about that. Several years ago, 5-6 years ago, I was in Rome at Dottie Fidel's conference that she has in Rome. And profilometry was just really getting started. And I was speaking on behalf of Zeiss. Pentacam, Oculus. They had developed the cornea scleral profile program where they were profiling the cornea. Yeah. So I had bought a Pentacam and I was helping develop that, beta testing it. Yeah. And Greg Denier was working with SMAP, with the SMAP. And then Greg Jamalis from Dallas, who developed his own technique using Visante OCT, and he used his OCT to design lenses, and he had developed his own program to do that. Quite impressive. And so I think I was first. I think Greg Denier was second, and then I think Jamalis followed us. And following all of us was Ken Pullum, and I think Don Ezekiel was there as well. And so Ken Pullum gets up. Of course, he's been in this for 40 years, and he's been doing impression molds and all this at Moorfields. And he gets up, and Ken has a great sense of humor, and he said, "Well, that's really interesting, guys. That's really interesting technology you got there." He said, "But it's really quite simple. You just take a lens and you just put it on the eye, and you just look at it." Exactly. He was kind of making fun of us. But I do like the technology. I think it helps you get to the end point a lot quicker. Yeah. And for people like Ken and Dottie and Christine and Melissa Barnett and all the Greg Denier, all these people, they've looked at so many eyes. They can literally put a lens on, look at it, and go 200 microns here, 100 here. They look at it and wave their wand, and it happens. But people that are just starting it or don't do as much as in a general practice, it's not what they do every single day, then the technology really helps, because it takes a long time to be able to tell up 50 microns from 100, if even ever. But if you have a profilometer or a good keratometer and can do a good map, at least the lens you order, and of course the labs really love that, at least the lens you order is going to be close. It's going to fit fairly decently, probably give you good vision. So the technology is not. So my advice is, don't think that you need a big scleral practice in order to invest in technology. Go ahead and invest in technology, as you're able to. That'll help you.
Yeah, thank you. finally, what would be, say, the red flags you would advise practitioners to look at when they fit scleral lenses in keratoplasty, post-penetrating keratoplasty? What red flags or signs would you say they should watch out for before saying pull these patients out?
Well, the things like edema, the things like wound leakage, obviously, excessive staining. Karen Karaskio from Boston Sight said every progress visit should end with removing the lens and staining the eye.
Yeah.
And in fact, one of the sessions that we're going to do at our conference in July is it's called it's called Forget the Plastic. Okay, forget the plastic. We all manage a disease process, especially in these patients, have a disease. So we need to look at it. So take the lens off and look at the integrity of the eye. One thing you always look at is edema in the limbus, microcystic edema in the limbus. We don't want to land on the limbus, but we don't want excessive clearance because we want good oxygenation. So, you look for areas of staining, any wound leakage, gapping. Watch for neo because neo can go very quickly, and it's real obvious. It's pretty easy to look at those blood vessels, but we should always look and assess the health of the patient's eye. Any eye, but especially with a scleral lens. So take the lens off and look. But again, jump in and do it. And going back to Ken, and where we have these up in Moorfields, who's done all these really complicated people for many years. And going back to what we said earlier about, well, are we not going to do something because something might happen? These people need help. They need to see. They need to go to work. They need to go to school. They need relief from pain. So I'm not going to stop. I'm not going to withhold a treatment that may be beneficial because of what might happen. You do the best you can. You do the best you can. You follow them closely. You're very responsible. And if something comes up, you deal with it. But you don't, anyway, you get the point.
Back. Yeah. Thank you so much for this. I think this has been helpful. And I think a lot of practitioners, whether experienced or new, would learn a thing or two from this. I think I'm just going to give you a chance to talk about the International Congress for Contact Lenses coming up in July. So can you tell us a bit about that, the dates, and what we're to look forward to?
Great. We'd love to have you. It is the International Congress of Scleral Contacts. The website is icscmeeting.com, icscmeeting.com. It is truly international, OB. Last year we had people from 25 countries, including Africa, Middle East, South America, Canada, Europe. So it's truly international. It's 2 days. It is July 28th and 29th, which is a Friday, Saturday. It's in Fort Lauderdale, Florida, which is just north of Miami. So, of course, Miami's a very large international airport, easy to get to. It's for every level. I mean, if you've never fit a scleral lens and just want to see what it's about, please come. Technicians are welcome. Office staff are welcome. There's a series of panel discussions. There are hands-on workshops. We have 6 different hands-on workshops, and we rotate through the workshops. So every participant will get to go to every workshop. You don't have to choose and feel like you're going to miss something. So that's about it. It's affordable. I think it's around $300 American dollars, and breakfast is included, lunch is included. And it's a small meeting, we expect between 200 and 300 people. So it's not massive. So you can talk to the experts, and we have the greatest people in the world. We have the true experts there, and we're very inclusive. We're very friendly. No question is, too silly or obscure. So, in fact, one innovation that I will mention that is a tremendous asset is we'll have 2 on the first day on Friday. We'll have 2 simultaneous tracks running parallel.
Oh,
One
wow.
is called Foundations, and Foundations is for people that are just really getting started in this, that don't have a lot of experience, that maybe fit a few, or maybe not very many, or maybe they're more experienced, but they want to know how to grow their practice and how do I train my staff. That's called Foundations, and it's going to be led by Brooke Messer and Jason Jedlicka, who are very, very well known and great people. So someone who's just kind of getting started, you would attend that track. And then the other parallel track is called Masters, and that is for more advanced practitioners who have some experience, who want to do more, who maybe are thinking about the next level of technology that they want to add, or they have more complicated cases, as like we've discussed today. So for people that want the next level, the cutting edge stuff, then the master's track would be for them.
Oh, well, thank you so much for that, and all the best. I hope you enjoy retirement, and keep speaking, keep talking, keep teaching us.
All right.
Very glad to have you today. Thank you so much for
Well,
doing this.
the pleasure is mine, and please keep in touch, and I hope you'll invite me back.
I definitely will. Thank you so much.
All
Enjoy the
right.
rest of your evening.
All right. Yeah, get some sleep. I'm sorry to keep you up so late.
No, that's absolutely fine. I'm good. Thank you
All
so
right.
much.
All right.
Have a
Thank you,
nice day.
Obi. Congrats and
Bye.
cheers.
Yeah.
Bye-bye.
Bye.